Hello. This is first case transmission from Nanjing First Hospital, China. And we will discuss something about the trifurcation lesion of this left main. And today's operator is Dr. Ge Zheng and his team. And my name is Dr. Fei Ye from Nanjing First Hospital. And I will ask Dr. Ge Zheng to introduce your heart team, please.
Okay, thank you, Dr. Ye, introduction. And today we prepare the case for the distal movement trifurcation. And first of all, I want to introduce our team. Is on our left, on our right is Dr. Gao and Dr. Chao, and our nurses and imaging technicians, Dr. Pan. And I would like to ask the Dr. Gao to introduce this case clinical information. Please, Dr. Gao.
Thank you. Please show me the slides. Okay. Hello, everyone. It's my honor to introduce this case. Next. This is a 60-year-old gentleman. 6 days ago, this patient was admitted into local hospital, presenting with sudden chest pain for 6 months. Emerging angiography at a local hospital found the distal left main total occlusion, but unfortunately, the walk wire could not cross the total occluded lesion. After intracoronary thrombolysis, fortunately, the blood flow recovered to TIMI-3. Then this patient referred to our hospital. His risk factors include essential hypertension and diabetes. Lab test at our hospital showed his eGFR was 45, and his BNP significantly elevated. ECG showed pathological Q waves in these V1 to V3. Echo found abnormal motion of anterior and posterior wall, and his left ventricular ejection fraction 48%. He was diagnosed as STEMI, cardiac shock, diabetes, and essential hypertension. Next. This is the ECG at our hospital, and the ECG showed pathological Q waves in V1 to V3, AVR segment significantly elevated. Next. Then second day at our hospital, this patient underwent coronary angiography with IVP support. The baseline angio showed mild to moderate stenosis in middle to distal right coronary artery with severe vessel tortuosity. Next. From epicardial view and spider view, we could find distal left main trifurcation, 90% stenosis in distal left main, and LAD ostium. The ostium or left circumflex and remers were almost normal, also with severe calcification. Next. From epicranial and iocranial, we also could find 90% stenosis in LAD ostium and moderate stenosis in middle LAD. We could find that the vessel was very tortuous and with severe aggravation. The middle remers, we could find a moderate stenosis. Next. The syntax score for the patient is 47. We also calculated the syntax 2 score. 4-year mortality for PCI was 10%. 4-year mortality for cabbage was 4.1%. After discussion with cardiac surgeons, this patient and his family refused cabbage. So today we plan to perform PCI for this patient. Next. Considering the distal left main trifurcation and cardiac shock, so we plan to perform IVUS-Guided PCI with IVP support. For severe calcification in distal left main and LAD, we may use rotational isolectomy or intravascular lithotripsy standby if needed. That's all. Thank you.
Okay, thank you, Dr. Gao. Introduce this case. This is today's angiogram. We can see it's distal left main trifurcation because the case is a STEMI patient with the intracoronary thrombolysis and with the cardiogenic shock. So use the hemodynamic support is very important for this case. And we target lesion today's target lesion is distal trifurcation. So we can open the discussion for this case.
So we think before the procedure, which kind of left ventricular support devices we usually use for this case? Just because we can see after antithrombotic therapy in local hospital, we can see the antegrade flow of the LAD and the circumflex was very good, but still severe stenosis located at the distal left main and the proximal LAD. So this is a typical trifurcation lesion, very complex anatomy of the distal left main. So we think the procedure of the PCI was not very simple, just because of how to protect so many side branch during the procedure. This is the first issue. The second issue, how to use intraosseous imaging guidance, OCT, IVUS, or just angel. The third is how to wire LAD. There's so many issues we should pay attention during the procedure, and before the procedure, we should make a lot of plans. So, Dr. Ge,
Yeah.
which kind of left ventricular support devices you will use for this case?
Yeah, it's an important question for this patient because the patient's cardiogenic shock.
Yeah.
So, probably we need the IBP, at least the IBP to support this patient. Because the patient will use the IBP to stable the patient, and pressure blood is okay, and more than 100 over the 70. So I think maybe IBP is enough for this patient. I don't need to ECMO or another mechanical support. So yeah.
Yeah, okay. IPP is enough for this case just because we can see before procedure, the patient hemodynamic status was very stable after IBP. So another question is, do you check the ACT before the procedure for this complex bifurcation lesion?
Yeah, we all really check the patient's ACT is greater than 400 seconds.
Yeah. The third is how to wire in the LED. Which kind of wire you will use for is your? I mean, so which kind of wire is your first choice?
Yeah, that's the key for this patient. I want to wire the LED firstly.
Okay.
So to shape the wire is important for this patient. So I want to zoom
Could you
this.
could you zoom the tip of the wire?
Yeah, okay. It's I want to use the run through wire
Okay.
to shape the two curve for this wire. To can you?
So use your hand
Yeah.
as a background. We can can show you.
It's a two
Yes.
curve.
Yes, we can see it clearly here.
Yeah. Okay.
So double angle
Yeah.
of the tip of the wire. So this is a key point. First, how to wire in the LED with so very angulation
Because
of the
this,
LED, this left main.
this
Yes.
LED is a big angle, so I think maybe difficult to wire this LED. Okay.
Okay.
So, it's 7 French from the radial axis.
Yeah. So we can see severe stenosis at the distal part of the yes.
Okay.
Okay, very easier for you to wire in LED. So we can see Dr. Ge use spider view and change to the AP cranial.
Yeah, to advance the wire into the test. Okay, we can see this
severe angulation. It is a proximal LED.
Yeah.
Yes.
This diagonal.
This is diagonal. Yeah. Second diagonal. This is, yes. You got it. So you want to use IVUS or OCT for your imaging guiding?
Yeah, that's a great question. For this particular patients, for the distal nerve main, I want to use the IVUS,
yes,
not to guide the PCI.
Yes, we think for the left main bifurcation or trifurcation, especially for we want to detect the osteo left main, IVUS is better than the OCT. And another question is the patient left ventricular function is not very good, so we don't want to use contrast so much volume, and You will check the IVUS directly or pre-dilate the distal left main.
I want to advance another wire into the ramus and the circumflex
Yeah,
to
yeah,
protect,
yeah.
and then check IVUS.
Yes, very, very good. Very important issue, how to protect the side branch of the circumflex and the ramus. Just because even though with a very sharp angulation of the spider view, we cannot see the trifurcation in detail.
Okay.
So many crossover
Okay.
phenomena
Another.
of the angel. So we will use the IVUS to check the LED, ostium, LED, ostium circumflex, ostium ramus separately. So just because very severe stenosis at the distal left main, you will pre-dilate the left main before IVUS checking?
Probably I want to use IVUS to check the lesion is sorry.
So which kind of this wire?
This is cyan blue.
Cyan blue.
Yes.
The second wire is
It's ABT is a domestic wire.
okay.
Okay, it's ramus.
Yes.
Okay.
So we can see Dr. Ge used 3 wire to go into the distal AD, distal circumflex, and the ramus.
Okay. Okay. No, it's a side branch. Okay.
Yes, okay.
Okay. Oh,
spider view?
Yeah, spider view. Check IVUS the first name. If the IVUS caster can across the lesion smoothly, I think probably don't need to preparation for this lesion.
You don't want to pre-dilate first before IVUS checking?
Yeah.
Just because distal left main was a very severe stenosis. If we check the IVUS.
Yeah.
Another question is just because there is IBP support.
Yeah.
We can see the whole procedure now is for the patient is very stable.
Very stable, yes. Okay. Move.
So we want to see the IVUS screening, yes, on the screen.
Yeah, I was here.
Any resistance? Or no?
No resistance.
Okay.
Okay.
Yes.
Dr. Pan?
It's not normal.
Okay, I advance a little bit.
We
It's
can
a normal
see.
vessel.
Yes,
Muscle
LED
bridge.
was.
Okay,
yeah,
this
yeah,
is
yeah,
normal.
it's nearly normal, but very distal.
Yes, I will pull back.
Yes, we can see the LED was diffuse lesion from the mid LED to the fracture part.
Yeah. The distal LED vessel is normal. The vessel diameter about 3.0.
Okay.
And then go pull back, we can see muscle bridge. And in muscle bridge, we can see eccentric plaque, and the plaque is calcium. And the calcified plaque angle is about 180 degrees. Then go pull back, we can see one small diagonal joining LED. And here, this is the proximal LED. The proximal LED vessel diameter about 4.0 millimeter. And here, the calcification angle is about 90 degrees.
Yeah.
Here, the vessel diameter about 3.5. And this is a proximal LED. And here is the attenuation plaque. And here we can see 9 o'clock, the ramus will join left main, and the circumflex join left main. And this is the POC, and this is the distal left main. And the distal left main vessel is more than 5.0 millimeter. 5.0. And here, this is the body left main, and the plaque burden are very large. This left main plaque is also calcified. The calcification angle is not more than 180 degrees. This is a body left main. The plaque burden is more and more smaller, and the diameter is about 5.0.
Okay.
At this point here, the lumen diameter is more than 4.0.
Yeah.
The left mainness is very long. And here, this is the proximal left main. And here is proximal left main is normal.
Yeah.
Okay,
Okay.
guiding.
To the guide. Okay.
Yes, from the IVUS from LED to left main, we can get a lot of data.
Yeah.
So, Dr. Pan, would you tell me which is the distal landing zoom of the LED, and what's the reference diameter of mid LED and the proximal LED and left main? That's very, very important. So many issues. Just because we want to use a stand crossover tactic from the LED to the left main. The question is any mismatch of the proximal LED reference and the left main reference diameter?
Yeah, the distal reference is 3.3.
This is distal LED.
Yeah,
Okay. How about the proximal LED?
this is the proximal LED.
Yes.
It's the Austin LED. The vessel diameter is about 4.5.
4.5. Okay.
Yeah.
Okay.
And the netness from the distal landing loop to Austin LED is about 34.
34.
Yeah.
That's very, very good. Very, very important data.
And the whole netness from the distal reference to proximal left main is about 70.
Okay. Okay. So, Dr. Ge, would you check another vessel's IVUS?
Yeah, I want to check the IVUS for the circumflex
Circumflex.
to make sure the ostium circumflex.
Yes. It's
Yeah,
easier
okay.
or not easier?
Is it easy? Is circumflex okay?
Yes, just because the angulation between the circumflex and the LED was very sharp.
Okay. And here I will pull back.
Yes.
Yes.
Yeah. The distal circumflex vessel is normal, and the vessel diameter about 3.5 millimeter.
3.5.
Yeah. And here we can see eccentric plaque.
This is a Remus.
This is yeah,
Uh,
Ramus and LED join left main.
So this
This is
left
distal
main,
left
this is,
main.
yes.
Okay, stop.
Okay, I will stop.
Yeah.
Yes.
Okay, I will check. This is the ostium circumflex.
Yeah.
I will check the
Is it-
area.
It's ostium. It's almost like seems like it's okay.
Yes.
The area is about 89
Okay.
meters
89.
square, and the plaque burden is about just 54%.
Yes. Yes. So, Dr. Ge, will you check the Ramas IVUS?
Yes. Just check Remus to.
So it's quite interesting. Quite interesting. Just
so-
because how to protect side branch during the one stand tactic crossover tactic.
yeah.
I think it's not a important issue we should discuss before we put stand. So I think IVUS result of circumflex is similar with angel result.
Yeah.
So the
Yeah.
osteo circumflex was nearly normal.
No more.
Yes.
Yeah. Okay.
Okay.
It's the Remus.
Okay, this is the Ramus. I will pull back.
Yeah.
The Ramus, proximal Ramus is normal, vessel diameter about 3.5.
Oh,
3.5.
yes.
Okay.
Yeah, and
So many huge side branch.
Yes.
Yeah. And here we can see side branch.
Oh, it's
diagonal.
normal. Okay, we can see this.
Okay.
LED and
LED.
circumflex.
Yeah.
Okay.
Yes, we can see it
Okay.
clearly.
Stop here.
Yeah, stop here. I will check the ostium ramus is normal.
Yeah.
It's normal, no plaque.
So summary for the IVUS detection, we can see the osteo circumflex, osteoramus was nearly normal, both. And how to protect the side branch. We don't want to touch the ramus, and that means we don't want to stand in the ramus and the circumflex. So, Dr. Ge,
Yeah.
so one stand technique is your choice?
Yeah, it's because based on the IVUS results, is ostium the circumflex or ramus is normal.
Yeah.
So I just want to use the wire to protect these two side branches.
Yes. Yes.
So first of all, I want to use the non-compliant broom to dilate this LED and the distal liftman.
Which size of the balloon?
It's a 2.5.
2.5 NC balloon
Yeah, and simple.
to pre-dilate.
Okay. 12.
So, Dr. Pan, could you tell me the plaque characteristics of the trifurcation site?
Okay, this is an ostium LED. You can
Yes.
see
Sure.
here. The cranial is no plaque.
Mm-hmm.
Maybe have a plaque shift.
Okay. Okay.
16.
Could you see the length of the cranial from the longitudinal IVUS detection? We cannot see it clearly. OCT may be better, but this is a displacement bifurcation lesion.
Yeah.
How to predict plaque shift or cranial shift after predilation of the main vessel?
It's a very big angle.
So from the IVUS, we can see the plaque characteristics of the main vessel opposite the side branch was not calcified lesion. So that's
14.
why we cannot see the cranial shift. If we can see the plaque characteristics was calcification opposite the side branch. If we predilate or standing main vessel, we can see the cranial shift easily.
Okay.
For this case, we cannot see the so many severe calcification opposite the side branch. So we predict there is low influence of the side branch flow and diameter stenosis after predilation. I guess. So after 2.5 balloon predilation, so next stage.
Yeah, based on the IVUS result, we can see some of the severe calcification located in the distal liftman.
Yeah.
So I use a scoring balloon, 2.75 scoring balloon, to prepare this lesion, calcification lesion.
For the distal left main or LED?
30. 30.
30.
Yeah, 30 for the
30.
distal liftman.
For this left main.
Yes.
So based on the IVUS detection, what's the reference diameter of the left main? 5?
5.
5. Okay. This is 30.
30, yeah. Yeah, because probably protruding some in the proximal LED. So here is just you use the.
Yeah, we think just because proximal LED reference diameter was about 3.5 or 4.5?
3.5.
3.5. I think 3.0 is a
Eight.
little undersized.
Okay.
This is 3.0?
Yeah, 3.0
Okay.
is balloon expansion very well. Here. 6.
What's the pressure?
6. 6.
6.
Okay.
Here is okay.
Yeah.
Just because at the angulation side, yes, here.
Yeah, here.
No, no.
6, 8.
Okay.
I think pre-dilate is the angulated side, LED.
Yeah. Okay. 3.5 non-compliant balloon. 3.5.
3.5. 3.5. 3.5.
3.5 NC.
The picture. Oh, good. What's this? Okay.
Could you show the original spider view? Original
Yeah.
to compare.
Yeah.
Compare with the final result. Original. No.
Fix.
Yes.
Fix.
Original. Yes. Reason. Over there. Yes. So final result, we can see the flow is very, very good.
Yes.
And we cannot see any influence of the osteoramus and circumflex. What's the size of this balloon?
It's a 3.5.
3.5.
Yeah. Okay.
How to precise located at the
6,
balloon side?
8, 8, 10.
It is 3.5.
10,
NC balloon.
NC balloon, yes. 10.
What's the pressure?
10.
10.
10. Okay. Okay. 6. It's in protruding the proximal LG.
6.
Okay. Here.
So based on the definition criteria, even though we don't use for the trifurcation lesion, but for your experience, how to define this trifurcation lesion, complex or simple?
Actually, for the definition criteria, is exclude the trifurcation.
Yeah.
Yeah. So probably for the LD and circumflex based on definition criteria, because the circumflex osteum is normal. So I think it's a simple bifurcation.
Yes, simple trifurcation.
Yes.
So based on the ABI ARC definition of bifurcation lesion from the EBC, this is also a simple trifurcation lesion with a medulla 1100.
Okay.
So another question, do you want to standing now or want to check the IVUS?
Yeah, I want to check IVUS.
Yes, check the IVUS. Yes, we will see your preparations result.
Yeah.
After 2 NC balloon, 1 scoring balloon. Flash. 我那个 IVUS 冲一下 ，flash。
OK。
So we also can see with the predilation of the vessel, the patient was very stable with stable blood pressure.
Yeah, patient
and
is
low
stable.
symptom. Yes,
No,
very, very stable.
Chest pain.
So we think IVUS is IABP is a good choice for this case.
Okay, I just want to from here.
Okay.
It's proximal LD.
Yeah, I will pull back.
Yeah, pull back.
ID vessel.
3.5.
About 4.
For
Here we can see
Yeah,
dissection.
it's larger
Yeah,
than
media
before.
dissection. It's a ostomy LED.
this is just
dissection
like a
length
logical
very long.
classification. Yes,
Yes.
very
This is the
diffusion.
bifurcation of LED and the circumflex. It's the POC. Circumflex guide wire. This is
Okay.
distal left main.
It's
Yes, we can
calcium the
see.
crack.
Yeah, the crack. Yeah,
Yeah.
the crack of the classification.
This is internal dissection.
Yes, this is criner, not criner.
The body left main.
Yeah, it's so. Oh, we can stop here.
Okay,
Yeah,
I'll
okay.
stop.
Okay. So then, 3.0.
Yeah.
So then,
So based on the ultimate trial, Dr. Gao, would you tell me the criteria of standing zoom selection?
Okay. Thank you, Dr. Ye. In ultimate trial, the landing zone or the optimal landing zone is the block burden is less than 50%, and no wrong plug.
Yeah. So based on the IVUS detection, we select the landing zone, the mid ALD without any plaque burden over 50%, no soft plaque there.
Okay.
What's the size of the stand, Dr. Ge?
it's 3 and 33.
33.
33. Yeah.
What's the brand of the stand?
Firehawk.
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 Okay, this
Okay,
is
it's
a
easy.
domestic jugular stand.
Okay. I'm gonna pull back a little bit on the here.
Back. Yeah. Yes.
Yeah, I think it's here. It's
I think
good.
yes.
Check the ostium or LD.
Yeah. It's
So first stand, you don't want to cross over the side bench.
yeah, I don't want to cross because it's a 3.0 stand.
Yeah.
I want to select another bigger stand
Yes.
to
Picture.
picture. Okay, and advance a little bit to under the ostium the circumflex. Okay. Okay.
Okay.
Here.
Yeah.
Okay.
So this is a 3.0 stand.
8,
Yeah.
Yes.
9,
But the
10.
proximal reference diameter of the LED was 354040. 40. So you will use a 4.0 stand to connect with the 3.0 stand.
Probably we use 3.5. It's enough for the
3.5 is better.
bed. Okay.
Reference diameter
Yeah.
4.0. Or from
Yeah.
media to media or
Media to media.
is 4.0.
Yeah.
Okay, 3.5 is okay.
Oh.
So, Dr. Pan, would you tell me the whole length of the distal landing zone to the osteo left main? The whole length?
70.
70. 70. What's the second stand size? 3.5. How about the length?
38.
38.
Today.
Okay.
Okay.
Okay. Good. I think.
Okay. 3.0 or 3.5. I think
3.5.
is both stand was okay. We have 3.5.
We also can see there is low influence of the osteocircumflex and osteoramus after predilate, after lesion preparation with a 3-5 NC balloon. And after standing, we also can predict the optimal result after standing. We think the cranial shift or plaque shift was not very severe there.
Yeah,
for
it's
this.
overlap. Sorry.
是你
Oh,
and
no extra.
Wait a moment. Bypass. Wait. Please try again.
Okay.
Okay.
It's overlap.
contrast, please.
Yeah.
Contrast. Okay.
Okay.
I think
No
Yes,
problem.
I think overlap.
Good.
Yes,
Yeah,
change
yeah.
another view.
We move to the
So how about the
but-
proximal landing zoom?
yeah. To move another view to check.
Yeah. The RL quarter is better.
Yeah, I think it's good. Pull back a little bit.
Yeah, I think so.
That's okay. Here. Up. Yes.
This is 3-5, 38.
38, yeah.
9, 8,
8, 9.
9.
Good.
Okay.
Okay. Okay.
So before you post dilation in stand, you will leave the wire there gelled under the stand, or just change the wire after protection, or just pull the wire back to perform the post dilation.
Yes, that is a great question for this bifurcation. So for this case, because this distal nerve vein trifurcation, I want to first to use the 4O non-compliant balloon to port the distal nerve vein, and then to exchange the rewire into the rams and circumflex.
So you change the wire after post dilation with the 4O. Yes, there is low influence of the circumflex and the ramus.
Okay.
From the IVUS, we can see there is not full any
5.
4-5.
plaque shift.
4, 5.
This is 4.
Okay.
4-5.
Sometimes we change the wire before post dilation. Sometimes we change the wire after post dilation. It depends on the operator's discretion. This is 4O balloon or 4-5 balloon?
4. This is
4
4.
balloon to post dilation.
To do the port
Yes.
technique. Okay. Here. Okay.
5.0的也背个。
Here. Okay.
10, 12.
This is 4O to do the port. And okay.
So this is the NC balloon for port.
Yeah.
NC.
Could you tell me is any difference of the port balloon compared with the NC balloon for port tactic?
Yeah. Actually, we have another port, like port balloon.
Yes.
It's very short to do the port. Like, okay.
14.
Another new one wire. Also.
So after personalization with full O balloon, what's your next strategy?
Next, I may want to change the sun branch wire.
Okay.
Okay, that's about the view.
So we still don't know for the one stand tactic, a crossover tactic from the LED to the left main for this left main bifurcation. And if there is no influence of the side branch of the circumflex and the ramus, do you perform the kissing or not routinely?
Yeah, that's a great question. So probably I have to, based on the post dilate the LD and the distal nerve main, and to check the ramus and the circumflex ostium to make sure if the cranial or plaque to move into the ostium, sun branch ostium, to design to post kissing balloon information or not.
Yes, there is no consensus of final kissing with one stand tactic post one stand means crossover tactic. If there is low influence of the side branch, even with large side branch or small side branches, there is no consensus of the routinely final kissing. So that means we don't know kissing or not, which is better. For the clinical outcome, there is no difference. For the maybe from the intravascular imaging result, kissing is better, but clinical result we cannot get the good result.
Okay.
Yes.
Keep it here.
Which kind of this wire
This roster wire.
you change? You want to change the wire?
Yeah, this is changing. It's the same blue. Yeah.
So any resistance?
Yeah, probably 1.5 blue.
1.5.
So
1.5.
okay.
1.5.
How to protect the jet wire technique? You use a small balloon.
Yeah, this more to support this wire to pull back properly. It's safe.
Okay. Sometimes we pull the jet wire. We can see the guiding catheter was protruded into the left main. Maybe will destroy the stand osteo.
Yeah, left main.
Dr. Ge use a smaller balloon. Which kind of a jet wire?
We say this wire is pull back smoothly.
Yes.
Here.
Yes, we can see after small balloon to protect the wire. The wire pulling back was very easier. So what's the next step?
Yeah, to change the wire into the circumflex.
Yes. Which kind of the wire?
This is CM blue.
New one. CM blue. How to make sure the wire was going to in the stand, not under the stand strap?
Yeah, sometimes we depends on some experience.
Yes.
Yeah, it's a wire is can advance smoothly. Yeah, so probably is in the inner stand. If the some the resistance is probably on the stand.
Yeah. So finally we can with the IVUS checking.
Yeah,
we will find very precisely.
So sometimes we need to knuckle wire in this.
Yes, this is technical issue. Use a knuckle technique.
Yeah, I think
sometimes we use double channel catheter. Sometimes we use IVUS checking.
Oh, it's, I think it's under the.
This is a cyan blue wire.
Yes, same blue. Okay.
Yes. Easier.
Easy.
Okay.
一点我去拿。So
Another issue is how to pulling back the jet wire in the circumflex.
okay, it's use the
Still use a smaller balloon.
yeah, it's some resistance.
Yes.
At
So we think a lot of methods to pulling back the jet wire. We can use a small balloon assist, and we can use the ankle technique with ankle balloon in the main vessel, and we also can
okay,
use another wire put into the
3O?
aorta.
3O non-compliant balloon to post dilate the middle LG.
3O.
Yes,
3O balloon.
Yeah.
Yes, angulation is,
Yeah, the
is very
angulation.
sharp. Everything.
Yeah. Okay, it's the here. Almost a little bit here. Test some
Okay.
more. Understand? It's not clear. Here. Okay.
This is 3O balloon for
Yeah.
postulation in the 3O
Sure.
stand.
14, 16, 16. Okay.哎呀，多么不算啊，打针，平均，那么肯定啊，16, 18, 18. Okay. 365，我们365的，我们365就好。16, 18, 18. Here, and go. 365高呀。Okay. 对。16, 18. Okay. 3.5?
3.5. You want to postulate
Yeah, Proximus.
LAD?
Yes.
Yes. After that, we check the
IVUS.
That's because postulation in left main is 4O balloon.
Yeah.
So what's the reference diameter of the left main?
5.5.
5. Okay.
Yeah,
Five.
After that, we will check if there is metaposition of the stand structure. We will use a large balloon.
Large balloon, yes.
Prepare the 5 balloon. Yes.
Prepare 5 balloon. Yeah.
8, longer. 5, 12. 8. Okay. Okay, no problem.
16, 12, 16, 14, 16. Yeah. Okay.
Even though with a very sharp angulation of the proximal AD and this left main, after standing, we can see the angulation was changed.
16, 18, 18.
Yeah.
Okay. 5. 5 balloon. 5 balloon. Yes.
How to precisely position the 5 balloon distally?
Yeah, yes, very tough. Sometimes we use the pot balloon.
Yes.
Yeah, for this conventional
NC
blind
balloon.
NC balloon.
Yes, this is NC
Yes,
balloon.
use the distal mark to
Okay.
precise this in the POC. I think the POC located in POC is okay.
Yes.
Okay.
Enough.
Yeah,
No,
enough.
little distant.
Yeah.
Just near
Pull
the
back, yeah,
POC.
pull back,
We
yeah.
don't want to cross over to
Yeah.
cross over the POC. Yes. Okay.
Yeah, okay.
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 The key point of the initial port and the final port. So initial port, we cannot cross over the criner tip. The final port, we just touch the
Okay.
POC enough. This is 5 balloon.
Yeah, this is 5 balloon.
Yes.
Okay.
What's the pressure?
It's 10.
10.
Yeah. 12.
12.
Yeah. Okay. Go to.
Deflection. Deflection.
Yeah. Okay. 12. 14. 14.
So we can see with the unprotected left main trifurcation region with the IBP support for this case, the whole procedure was very, very stable. The key point of this procedure is to make sure the stand shoulder was in the stand.
Okay.
We cannot touch any area beyond the stand. Okay.
Okay. We
This
check
is 5.
IVUS.
Yes, we check the IVUS.
OK，这还有一点，我觉得还得打一下。OK。Yeah.
So yes, Dr. Go, you tell me if you find some phenomena of the IVUS finding, you will use another stand cover the stand edge.
Probably.
IVUS preparation.
IVUS is okay.
Ready?
We can see the patient's heart rate and blood
So
pressure was
take a
very
shape.
stable.
Yeah. Okay, good.
Okay.
Spider view. Spider view.
Okay.
Good.
Okay.
Okay. Here.
IVUS?
IVUS.
Yes.
Open it. It's
Here in the stand.
Please more distal.
you know.
Okay.
Okay.
Yeah.
I will pull back.
Yes.
Yeah.
This vessel is normal. The distal stand edge is normal in low dissection, and the plug burden is not more than 50%. And the stand diameter is about 3.0 millimeter. One small septal. Here, this diameter is 3.0. The proximal LED. standard diameter more than 3.0. It's about 3.25. Center is more than 3.5. This
Yeah,
is
very
a
good. Yeah.
Austin LED. Maybe 9 o'clock. You can see the side bench. Oh, here. 8 o'clock
Yeah, you can
side
see
bench.
here.
This is circumflex. Distal left main. Maybe the distal left main vessel
With another,
diameter is not very large.
yes, we can measure it. So what's our criteria of the optimized result after manifest standing, Dr. Ge?
yeah, based on Excel study, probably it's 6, 7, 10 from the circumflex ostium and
Yes.
LD circumflex ostium and distal nerve main.
Yeah.
That's optimized criteria.
Mm-hmm.
The body left main standard diameter is more than 4, maybe 4.5.
Yeah. So we want to know the distal left main, Mary.
Yeah, probably we need a larger balloon to postulate.
Okay.
Standard is over.
It's okay.
Yeah,
will
it's
stop.
okay.
So we,
Okay,
we
good.
can measure the distal
Distal
left
main,
main
yeah.
area.
That's
Yeah,
If there is still on the expansion, okay, we can use
this is a distal left main.
yes.
yes.
I will check the area.
Yeah. Oh,
No, sorry. Area
10.
not more than 10 millimeters.
So how about the
Yeah, we just
8.6 millimeters.
2.6. You prepare the 4.
Yeah,
how about the expansion rate? For
I think
for the how about the left main reference area? Enough. Lumen area. Yes,
area is
lumen area.
enough. Yeah.
Lumen area. We can use measure the.
Yeah, we-
Okay.
14.
yeah, 14. This is
So
a
expansion was
proximal
about
standard area.
60. I mean, this the left main.
So
No. This is a proximal left main.
Yes.
shall I use the 4?
This is a proximal.
Yes.
Okay.
Okay. Thank you.
Some-
Thank you
some-
very much. Thank you. 那个我们要过去那个，过去一下。
对。